He went ahead and told me, I know I'm going to die, and before I die, I want everybody in Kenya to know what is going to kill me. My name is Evaline Kibuchi. I'm the Chief National Coordinator, Stop TB Partnership Kenya. I've been in TB advocacy for about 15 years. It has been quite an exciting journey. I am quite excited at seeing the progress that has taken place while I have been at the helm of the leadership around TB advocacy. My advocacy for tuberculosis came by chance. I applied for a job, a TB advocacy program officer. It's when I got the job and learning my terms of reference and understanding the magnitude of the problem that made me change my attitude. Initially, I was just like any Kenyan who thinks, TB is not a problem. Who dies from tuberculosis? In fact, many people think TB ended in the 80s. That was my attitude then. But when I got to that job, I learned the statistics and I came face to face with the suffering of people suffering with tuberculosis. That's when I thought I needed to go a step further to make an impact. So one day, there's this young man who wrote to me an email and he told me, I am suffering from a strain of tuberculosis that is not curable. First, I was taken aback. TB that is not curable? I thought TB has a cure. He went ahead and told me, I know I'm going to die, and before I die, I want everybody in Kenya to know what is going to kill me. So I am planning to do some small pamphlets, and I'm going to go to the top of this building, some building in town, and I'm going to spread those papers down to the streets of Nairobi so that everybody knows that there's this strain of TB and that I'm dying from it. Then I told him, before you do that, can you come, we have a discussion. First, I understand what is this TB that is killing you and why don't you have a cure? That's when I learned he was suffering from multi-drug resistant tuberculosis. Multi-drug resistant tuberculosis is that tuberculosis that has resisted the regular TB treatments. That means it needed a more stronger combination of treatment, which by then we did not have as a country. And that's why he had been told, we don't have drugs in Kenya, and so your fate is that you're going to die very soon. So we met, we discussed, and long story short, I was able to connect him with an organization known as MSF that was offering the multi-drug resistant TB treatment, which took 24 months. And the first 6 months of daily injections in combination with about 17 tablets. He was lucky he was put on treatment. From then on, I decided, okay, I first want to understand, why don't we have treatment in Kenya? Why would somebody be dying from a disease that we were told is preventable, curable, and treatable? Something was not right. And that's when now I delved deeply into TB advocacy. And that's what I have been doing for the 15 years now. I want to differentiate between creating awareness and advocacy. Many people take creating awareness as advocacy, but the two are totally different. Creating awareness is a strategy in advocacy. It's normally the first step in advocacy, so that you create awareness, you sensitize people about an issue so that you have a buy-in from them and so that they can work with you in whatever it is that you're advocating for. So you have to engage the political leaders. You also have to engage members of the fourth estate. I also work with former TB patients and would want to use their experience for two things. One, for advocacy around tuberculosis, and also to support in community interventions. For example, supporting those people who are already infected with tuberculosis to adhere to their treatment, and so many other community interventions that can be done by people who have gone through the experience. And again, for that purpose, my organization is a secretariat to what we call the Network of TB Champions in Kenya. And whenever there is need for advocacy at the national level, then we also engage them in doing that. Kenya is one of the countries globally that have the highest burden of TB. At the global level, we have 30 countries that contribute to 80% of the global TB burden. Kenya ranks about number 11. And that is the same trend with HIV infections. So there is that link between TB and HIV. And when we look at the impact of tuberculosis in this country, we are losing about 21,000 lives to tuberculosis every year. And this is a decline because before COVID, 2019, for example, we lost about 31,000 lives to tuberculosis. We have very low levels of awareness about tuberculosis in this country. And therefore, even when people get infected, they do not know that what they could be suffering is tuberculosis. They think it's pneumonia. They think it's a common cold. And so what they normally do, go over the counter or self-medicate, or, as usual, boil ginger lemon and hope that the cough is going to go away. That is the biggest challenge. And the longer you stay without treatment, the longer the disease destroys your lung, and the more you're infecting other people. Remember, it's infectious. So you're living in the house with your brother, with your sister, with your wife, with your children. You have this disease that is passed through air and is not treated. And so you infect a new member of the family. This next challenge is TB. I call it a socioeconomic disease more than a biomedical problem, because the factors that contribute to the spread of the disease are more social and economic. TB will thrive best in a place that is poorly penetrated. It will thrive best in a place where people are congested. It also thrives in a person with lowered immunity. Lowered immunity could be brought about by many factors, including malnutrition. Malnutrition is likely to be found among people who are resource-limited settings, without much resources. When you compare the prevalence of tuberculosis in the developed world and in the developing world, it's totally different, because the living conditions there are way better, the access to medication. The other problem is access to medication and diagnostic facilities. We still don't have adequate, for example, diagnosis and also access to treatment. The other challenge is funding. We are still relying, at the national level, we are still relying on international donors. We are funding about 41% of our TB response, and about more than 50% coming from donors. If you look at most counties, they hardly allocate any money to tuberculosis because they think tuberculosis should be funded from the national government. Therefore, so many interventions go without adequate attention because of lack of funding. We have an innovation, what we call the TB ATMs. TB ATM is just like an ATM where you go and you self-screen. Another innovation is screening anybody who appears in a health facility. Whether you're going because you're sick, whether you're going because you broke your leg, or you're a border rider going to take somebody to hospital, so long as you found yourself in the compound of a health facility, you're screened for TB. That was piloted in Kisumu. And again, it is amazing how many people went to the facility not because they were sick, but when they were screened, they had tuberculosis. The next innovation is engaging the private sector, especially the pharmacists. So the pharmacists are engaged to screen anybody who comes to buy a cough syrup or anybody who comes with a cough. So many people have been found positive of TB when they went to buy cough syrup. The government has also gone out of the box to engage what we call the informal health services providers, the herbalists. The government is trying to do whatever possible to ensure that we arrest the spread of this disease and that we reduce TB-related deaths. I'm proud to have seen so many transformations during my reign in advocacy. When I entered into TB advocacy, there was this practice of jailing TB patients who failed to adhere to treatments. But prison is for criminals. TB patient is not a criminal. When I came in, we joined with other TB advocates, including an organization known as Kenyan, Kenya Legal Aid Network. And we went to court and we agitated for review of this practice. Kenya was the first country in the world to review that law, and right now it's outlawed. When I came to the scene, there was also this very punitive policy for drug-resistant TB patients. Countries used to be given a limitation as to how many patients they can put on treatment. And by then, Kenya had only been given approval for 40 patients. So the rest used to be they are tested, they are confirmed they have drug-resistant TB, but they are put in a waiting list. Of course, majority of them died in that waiting list. When I came in, I thought, this is violation of human rights. How can you put a patient in a waiting list for 2 years? We did a lot of advocacy through the Minister for Health, by then she was Honorable Beth Mugo, to review some of those policies and also push stakeholders to give some social protection, some allowance to enable these people to be able to come to hospital every day, to be able to get proper diet. And that's how we started the policy of 6,000 Kenya shillings per month for any MDR, drug-resistant TB patient. Up to now, that provision is there. Secondly, we also pushed for the patients to be put on NHIF. So as soon as you're confirmed you have drug-resistant TB, you are put on NHIF and you are entitled to 6,000 monthly for the 2 years until you finish treatment. Back then, there was only one technology, microscopy. We're only using microscopy to screen for TB. Microscopy comes with its own challenges. One, it does not detect drug resistance, and it's not very sensitive. It can report your negative when you're actually positive. So we used to miss quite a number of people who are positive because of the insensitivity of the technology. Quite excited now to say that we have treatment that does not have injectables, they don't have side effects, and they are shorter. We do not have TB prevention technology. Right now we have a drug you can take when you're not infected with TB to prevent you from getting tuberculosis if you're exposed. There are quite a number of steps that need to be taken. One is to invest in a lot of awareness. I look forward to a day when the government investing in every media house to talk about tuberculosis, like they did for COVID. In 2 years, everybody was aware of COVID. We still have not gotten there in TB. Why? The stigma. And stigma can only be addressed when there is a lot of awareness so that we stop associating TB to HIV. We stop thinking that TB is a disease of the poor. Anybody can get TB so long as you're breathing. We stop taking TB as a disease of the developing countries and come to accept that TB can affect anyone. Once we accept that at a global level, then we will start seeing even advocacy, being embraced by everyone. Much as we're talking about this political commitment, I look forward to an advanced level of political commitment where even the president will one day stand on a podium and say, TB is a problem in my country, and I am committed to ensure that I end this disease, during my reign. I look forward to such commitments. I also look forward to a place where we shall integrate TB into the basic levels of education, curriculums. I also look forward to embracing what we call the mass-sectoral approach, where we remove TB from being a biomedical problem, like I mentioned before, and look at it as a socio-economic problem, and have every development sector look at TB and see what is my contribution as a sector towards TB and towards ending it. If we have all the sectors playing their role, then we say we are going to end TB. You need to look at where you are and see, what can I do with my settings? You're a media person, for example. You can use your platform to create more awareness. I am a teacher. I can use my setting as a teacher to teach more about tuberculosis. If you're infected, get treatment fast. That reduces your chances of infecting another person. If you have somebody who is infected, your responsibility is to support them. If you have somebody who is infected with tuberculosis and you're living with them, I say, you are exposed, you're vulnerable to TB. Go for the prevention therapy. It's available in quite a number of public facilities. Anything you can do to reduce your chances of getting infected. TB is not just a cough. You can get TB in any part of your body, apart from the hair, the teeth, and the nails. And when TB gets to any part of the body, it presents with different symptoms. It does not present with a cough. You will never know that you have TB until you go to hospital and get checked. I would urge every Kenyan, make it a practice whenever you have any ailment, any discomfort, go get checked. So let's be very vigilant about tuberculosis in everything that we are doing. And by that, we are going to reduce the negative impact that TB has had, not just on the social aspect, but also on the economic aspect of our country. We can end TB if each person plays their role within their settings.